Being from the U.S. and with the many problems that our healthcare system has, I'm always somewhat surprised when an international audience is interested in hearing what we're doing across the pond. When an invitation like this pops up, I'm immediately reminded of a story about 3 Oregon elk hunters. And with advanced apologies to those who are offended by the idea of hunting game, we think of ourselves as great outdoors people in Oregon, and the story is told of 3 elk hunters who flew off in a light plane to a remote mountain lake to hunt for elk. When the pilot came back to pick them up at the appointed hour, he was disappointed to see that rather than the 1 elk that he told them they could take back, they had taken 3 elk. And as he berated them for having taken so many elk, they said, "But wait a minute, last year you told the same thing to our buddies, and they paid you twice as much, and you let them take 2 elk. So what do you say? We'll pay you 3 times as much, and why don't you let us take 3 elk?" Finally, the pilot acquiesced. They loaded everything on the plane, and as you might guess, the plane had trouble getting off the water, barely got into the air, and crashed into the trees on the other side of the lake. One of the hunters who had been rendered unconscious in the crash finally woke up. He looked over, he saw the pilot, he said, "Oh my God, what happened?" And the pilot said, "Well, we crashed." He said, "Oh gee, you have any idea where we are?" And the pilot said, "Yeah, I think we're about 200 yards from where your buddies crashed last year." So all that's to say, I hope this is useful to you, even if only as a cautionary tale, and that perhaps it'll keep you from flying into some of the trees that we've already hit in the U.S. So I'm really cognizant of the fact that whenever we're trying to transfer the use of something done in one country to another country, we have to be really conscious of the culture of both countries when we try to make those transfers of information. And just take these examples from the US and Canada and the UK as an illustration of that fact. In the US, our Declaration of Independence asserts the right to life, liberty, and the pursuit of happiness, while the fundamental law of Canada that serves as its constitution guarantees its citizenship, peace, order, and good government. In England, we have folks recoiling from the idea that health service availability could be decided by a postcode lottery. And in the US, once again, we have some states that provide almost universal access to healthcare coverage, while Texas, as an example, has 1/4 of its population without any healthcare coverage at all. So I think it's this combination of unique cultures and the opportunity for sharing is what made the OECD argue in its report, Healthcare Systems Efficiency and Policy Settings, that big bang reforms involving a shift from one type of healthcare system to another are not warranted. Rather, countries should adopt best policy practices implemented by countries sharing the same type of system while borrowing the most appropriate policy elements from countries with different systems. Now, if done correctly, I believe that using research evidence to inform policy is one endeavor from which all health systems can benefit. And today I'll describe the experience of some collaborative projects among American states to commission research, protect its independence, and then to distribute it through processes that enhance the chance that the research findings will inform policy and practice. Now, the information I'll share with you today comes not just from the current work that I'm doing with states, but also from over 25 years of experience in making health policy and in working with the Oregon Health Plan. Now, there I experienced firsthand the importance of evidence, outreach, and governance in policy making. In 1987, as Chief of Staff to then Senate President John Kitzhaber, I defended the initial crude priority setting process and then participated directly in the creation of the current priority setting, outreach, and budget linkage processes that are still used today. Those lessons continued as a governor's policy advisor, where we began to use systematic reviews to inform our pharmacy purchasing policies, and now in working with 2 multi-state collaborations. Now, being closely involved with the Oregon Health Plan was a great way to start in health policy, I'll admit, and I fully expected that as time went on, there would be some other states and perhaps even some other countries that might take on a similar approach to healthcare priority setting. After all, most people said, well, gee, this is really fair. It uses the best available clinical evidence. It's sustainable and realistic, and so on. But as an old wag once said, theory and practice are the same, but in practice they ain't. And today, the number of states and countries that have actually adopted something like the Oregon Health Plan stands at a grand total of 2, the state of Oregon and the Islamic Republic of Iran. Theory is to practice as evidence is to policy. True or false? Okay. Well, now, this is quite a group. Let's move on. So my most recent experience now comes from work with the Center for Evidence-Based Policy and with 2 multi-state collaboratives I briefly mentioned earlier. The center is an independent center located within the School of Medicine at Oregon Health and Sciences University, and its mission is addressing policy challenges with evidence and collaboration. It was established in 2003, and it builds on lessons that we've learned in public policy. In improving public policy, it's a collaboration of academic, public, and private nonprofit sectors, and it supplies original research and technical assistance to state policymakers, provides staffing and facilitation for building multi-jurisdictional collaborations, and we also do stakeholder outreach and communications. Now, before I talk about the collaboratives in some detail, I just need to give you an idea of some of the diversity of the states that are in the collaborations. So we have states from out here in the Northeast where we see some of the greatest population densities. In fact, we have the 2nd most populous state in the country involved in one of our collaborations. And then if you come out here to a little state called Wyoming with about 600,000 people, it's also in that same collaboration, along with folks from the West Coast and the southern U.S. So it's a real diverse group. As a matter of fact, we see the full range of political ideology represented within our collaborations, from some of the reddest of red states that had very high voting percentages for John McCain in the last presidential election to those that supported President Obama. And we also have an enormous amount of variation in terms of expenditures related to Medicaid. However, there's some similarities as well, and chief among them is the fact that 49 of the 50 states are constitutionally required, by their own constitutions, required to balance their operating budgets, so they cannot deficit finance like our federal government can. That means that, as a result, they have between 2 and 25% uninsured citizens in each. And so what that means is they all ration health care in one way or another. And while Oregon explicitly prioritizes health services and attempts to ration by priority setting, other states will ration by eligibility. That is, one day you're poor enough to qualify for a state program, the next you're not, or by cutting provider payments to the point that they won't take public patients, or by eliminating large categories of service that are designated by federal policy as being optional without any real linkage to clinical value for those services, I might add. So let's go on to the first of the collaborations. The first is the Drug Effectiveness Review Project. It presently has 10 states involved and the Canadian Agency for Drugs and Other Technologies in Health. It was established in 2003 and to date has focused on creating comparing the effectiveness, systematic reviews comparing the effectiveness and safety and effect on subpopulations of drugs within classes. This effort has developed its own systematic review methodology that's based on the work of the U.S. Preventive Services Task Force, which of course draws heavily on international evidence synthesis standards. It's financed by each state paying an equal share in a subscription to support the administration and the research provided by the collaboration. Officials responsible for running state prescription drug programs govern the collaborative to meet their needs by setting research agenda, allocating resources within the project, and they also select drug classes for review. They finalize key questions. They set policies guiding outreach and disclosure. They determine when the reports are final, but they have no say in what they contain. The governance process is conducted through monthly telephone conferences and then 2 face-to-face meetings each year. Substantive communications with the industry is exclusively in writing. The Drug Effectiveness Review Project does not make or recommend policy. The project is a prime illustration of the concept of globalizing evidence and localizing decisions. The states involved have pharmacy and therapeutics committees that use the research to guide the selection of their preferred medications in open public processes. All cost calculations are done at the state level, and CADIF provides the research to their provincial officials for use in their drug programs. However, the Drug Effectiveness Review Project is now beginning to reconsider the products it produces. While we've focused primarily on comparative effectiveness within classes, there's a growing interest in single drug reviews by virtue of the fact that there are such expensive biologic medications and new drug entities for rare diseases. Outreach to stakeholders within the Drug Effectiveness Program is routine and thorough. Any interested party may request all DERP communications, including draft and final key questions, draft and final reports, comments received in peer review processes. Each manufacturer of medications in the US and Canada is notified when their medication is to be a part of a review and a dossier of information is requested. The information received is made available to the public on request. Each set of key questions and draft final reports are posted to the project website, and public input and feedback is requested. While the research process is fully transparent, the DERP governance process and its meetings are closed to the public and industry. Now, the second multi-state collaboration, this one has 12 states in it, is called the Medicaid Evidence-Based Decisions Project. It's built on the same funding, finance, and governance model as the Drug Effectiveness Project, but it differs in subject matter and research methods. There's approximately a 50% overlap between the states' membership between the two projects. Subjects researched by the MED project range from diagnostics to procedures to medical devices, including durable medical equipment, and even to program evaluations such as disease management. Where each Drug Effectiveness Review Project report is a full systematic review, MED employs a range of methods from quick literature searches designed to assess the level of research available to full systematic reviews. To date, the officials that participate in MED have elected not to finance any full systematic reviews with their limited resources. The expense and the time it takes to complete a systematic review, and the fact that in many cases good quality systematic reviews on the subject often already exist, push them in a different direction. Rather, they utilize rapid best evidence reviews drawn from core sources known to produce high quality evidence appraisals, and then depending on the quality of the evidence and the currency of the search dates, they may do an update search just to see if there's any reason to question the conclusions that are already reached. Okay, here's your second question. Let's see if we can do something besides 20% split on each one. The MED project does not do full systematic reviews for each topic because they cost too much. Sometimes evidence is obviously very poor, etc., etc. So there we go. Ah, look at that. Somebody was listening. That's good. Okay, great. Thank you. Okay, let's move on to lessons that we would like to share. The first is to generate research relevant to policy. Policymakers should be involved directly in the research, in setting the research agenda and in prescribing the report formats. Neither of the multi-state collaboratives I've mentioned would have existed without policymakers being convinced that they were in charge of the agenda and agreeing and guaranteeing that the products they would, that are produced would be useful for informing the difficult decisions they face. Evidence is universal, but there needs to be a local hook to justify the connection to local policy. Evidence from afar is useful only if it's validated by a credible local process confirming its quality, its relevance to local conditions, demographics, and institutions. And in a slight twist to this need for local validation, the states have found that having other states involved in the process and having other states with similar policies has actually been very beneficial to them in sustaining their use of evidence to inform their policy. The requirements for a local hook, however, doesn't extend to research methods. Here, the states are more likely to accept national or international standards as validation that their own process is being conducted with the desired rigor and objectivity. So well-informed policymakers are reassured by the use of methods such as grade and agree, for example, as long as they're applied and validated by researchers that they know and trust. Next, not everything requires a systematic review, and one of the most important elements of applying evidence to policy is first understanding the needs of its end users. Factors such as timing of a decision, scarcity or plenitude of evidence, nature of the disease, and advocacy surrounding it all will affect the type of evidence analysis required. In some cases, a decision can be quickly made based on the lack of evidence or on exceedingly strong evidence. In other cases, decision makers will require a full de novo vetting and synthesis of the research evidence to be satisfied that they're making a correct and sustainable decision, but they don't require a full new systematic review to answer every question. Lastly, agenda setting among diverse organizations is really a challenge. So the states all have varying needs from the research, and one of the critical elements of our work with the states is to staff the administration of the collaboration so that each state actually can pull much more value from the collaboration than they would otherwise be able to do if they were trying to fund all of this on their own. So lessons learned in outreach, proactive communications, no surprise here, full transparency combined with purposeful outreach strengthens the credibility of the evidence process among most constituents. While some vendors and advocacy organizations associated with them will always seem to feel that questioning the value of their service or their evidence is something close to heresy, the public and even the legislative bodies can generally be brought to respect the research process and the evidence through outreach. However, depending on the issue at hand, the process must be more than simply placing a couple of advocates on an advisory board and then talking past them. Education of a broad cross-section of constituencies and effective messaging is required to keep logical decisions from being undermined by those with vested interests and emotional anecdotes. Similarly, the process must be more than just asking stakeholders what they want. To avoid the outreach process becoming a contest between disease advocacy groups, each competing for a larger share of the budget dollar, outreach is better structured by starting with a higher level questions around values and principles, and then using agreements on those larger, higher level questions to frame the discussions about specific needs and interventions. On particularly sensitive issues such as mental health treatments or treatments for autism disorder, for example, some states have used special working groups to fully flesh out the subtleties of these conditions and the policies that affect them. Lessons learned in governance. First, governance of research collaboratives, since we've gained a little bit of experience here. In research collaboration, patience is the byword. Collaborations of dissimilar organizations with similar missions take time to mature. Finding the right blend of research rigor, timeliness, and communications processes can take considerable effort. If our experience in the MED project is any indication, these key elements may continue to evolve as the needs and capacity of policymakers develop as well. Agreement on research methods is only a part of the challenge. Agreement on how decisions will work agreement on how decisions will be made and resources allocated and accounted for is hard work. It's important to invest in staff support sufficient to manage administrative tasks such as budgeting, communications, and contracting, because without such support, relying on in-kind contributions from participants can create inefficiencies, hard feelings, and ultimately make the collaboration more work than it is a help. And a difficult task within the collaborations is the priority setting, as I mentioned before, and having a facilitated process that ensures the states receive value that far beyond what they have put into it is very important to making the collaboration sustainable. Now, in policymaking, we have found that clinical knowledge and administrative ability are not the same thing. While clinical knowledge is a signal of intellectual ability, it far from guarantees that its possessor will be successful in administering health organizations and making large-scale policy decisions. In our multi-state collaborations, we found that understanding clinical implications of the evidence we produce is only the first step. In the MED project especially, the Medicaid medical directors, who are our primary interface with the program, often request additional support in data analysis, policy design, and in managing advocacy and interest groups who bring pressure to their decision-making. While the democratization of health care is rhetorically attractive, conjuring thoughts of responsible citizens thinking carefully together about what is best for their community and their country, in reality, the overwhelming presence in state governance processes is industry. Industry has the money to have lobbyists, scientists, and advocates present at every opportunity. To paraphrase the truism that there's no location fix to personal problems because no matter where you go, there you are, in healthcare governance, no matter where you go, there they are. The challenge is how to give industry the ability to provide legitimate input into the process without it becoming unduly influential. And the states are finding that vigorously enforced conflict of interest policies are only a starting place. Transparency in decision-making and the role of evidence is a hedge against a criticism based on process. In our experience, when advocates or industry cannot overcome the evidence available, they'll move on to trying to attack the process of decision-making and of bringing the evidence forward. Even though transparency is more work up front and sometimes seems risky, it prevents sniping related to process concerns and keeps good policy from being overturned for reasons unrelated to the evidence. Finally, the burden of proof. States are increasingly realizing that many of their difficulties derive from the fact that industry and advocates have succeeded in turning the burden of proof argument against them, making it the responsibility of the states to prove that something doesn't work before they can decline to purchase it. While states are working hard to remedy this, they are often frustrated by court rulings that require them to provide services that have no good quality evidence supporting them, but are vigorously endorsed by doctors or other experts. And there's a growing interest among the states participating in MED project to reach out to administrative law judges and other officials who hear policy appeals. So in conclusion, I'll return to my first point. Now, there are some in America and elsewhere that argue that the U.S. is exceptional, and I agree. But so are we all. We each have our exceptional qualities and challenges, and as much as we can learn from each other, we can seldom copy one another verbatim. One enterprise that can be helpful to us is to use good quality research evidence to inform our decision making. And to that end, the work that is done in the public interest in one place is useful to all of us who are similarly engaged. Every time a jurisdiction creates good quality research, protects its independence, and applies it to policy, an example is set that all of us can build on. But when we use those examples to affect policy, we have to account for our local culture. To fail to do so will diminish the credibility and the impact of the evidence in shaping our policy. Finally, from hard-won experience over the years, using research to inform policy requires great patience. Policy change is a process that even in times of great foment takes patience and judgment. As a recent Donnybrook over breast cancer screening recommendation shows, even when the evidence suggests that we are very right, we should be cautious of overreaching and careful in our communication. When the victors in a policy argument overreach, they risk creating a backlash that not only threatens the progress made, but can lead to reactions that will harm the effort of creating and protecting and using research in the first place. Thank you very much.
Good morning. Tom Jefferson. I work in Rome. I'd just like to start from one of your last comments about the US being exceptional. Well, if it is, it's as exceptional as Italy, because most of the comments you made apply to some of my work with decision makers in Italy too. So this business about the US being exceptional, I would take the same line as you did. I've got two clarification questions. The drug review program that you mentioned, and you mentioned doing systematic reviews within the program, are those systematic reviews only based on published information?
The answer is primarily yes, and we recognize that that is a potential weakness in what we're able to do. Now, we do use unpublished data if it's brought to us, but we will not use data that we cannot disclose. So when we go to the drug companies and we say, send us the information you have if it's relevant to these key questions, they send us unpublished studies or unpublished data, then we'll factor that in. We'll critically appraise it by the same standards we use for everything that we find on our own, and then we'll factor that into our research. But we'll always disclose it if somebody wants to know what it was.
Thank you. Briefly, the second one is the Medicaid evidence-based program, where you appear to say there was a eclectic program using different sources, from existing systematic reviews to updating systematic reviews. So then you said, I think you said rapid reviews as well, and I was just going to ask you whether you had a set program or a set definition for all these, yeah, and whether you used horizon scanning reports as well, since you put up a slide of a diagnostic or a large diagnostic machine.
So we do provide scanning reports. One of the briefest reports that we supply to our participants in the MED project is simply a look at what research evidence is available. So we'll do a search for them, we'll report that to them. Moreover, we tend to start out with a set of core sources. So BMJ, Clinical Evidence, Cochrane, NICE, AHRQ in the States, and so on and so forth. We have a set of core sources that we scan first to see if there's any high-level evidence that we might be able to use that would help us jumpstart making a response to the questions that the policymakers have. We have created a methodology around the rapid review process that we do, so that we can disclose that at any time if folks have questions about how we used the evidence, where we looked, and what we did. So we have a process we work through. Our states are comfortable with that. They know when they get a rapid review, they know what process was used to develop that for them, and then they know what the strengths and the weaknesses of that particular research piece will be.
I have a question that's a kind of a background question. I see policy and evidence as two ends of a continuum, because evidence is based on the search for an objective truth, whereas policy is based on values. So if you're using evidence to make policies, then for what do we need the politicians?
That's a great question. What we like to say is that evidence is essential but not sufficient, and that judgment is always required. So it's very seldom that a look at the evidence will give us the full answer to a particular policy question. And even if there's a strong suggestion of one way to do something or another relative to policy, that still has to be it has to stand the scrutiny of whatever public governance processes that are required to run a state and to run a public program. So it's a combination of the two, essentially. We utilize evidence to inform the values debate, to inform the policy work ultimately that gets done. So Some will say that calling it evidence-based policy may be overstating the case. I think perhaps saying evidence-informed policy may be just a bit clearer.